So today it's a real pleasure to introduce Nadeen Faza. So Nadeen came to us from Jordan, where she went to medical school. And Nadeen is a little bit too modest to tell you this, but I was able to extract some information from her. So Nadeen actually graduated top of her class of 170 students in medical school. And in fact, while she was a medical student, she was awarded a scholarship by King Abdullah to do an internship at Yale as a medical student. So that may be one tidbit about Nadeen that everyone doesn't know. She came to the U.S., did a postdoc training at Rush University, did her internal medicine at Cleveland Clinic, cardiology at Baylor College of Medicine, where she's already demonstrated herself as a rising star, was selected to be the chief fellow. And then she's been here at Houston Methodist for the last year as an advanced structural imaging fellow, I guess our first structural imaging fellow that we've had. And since we're so delighted with her, we decided we don't want to let her go. So she's going to start as faculty here at Houston Methodist July 1. So one other thing about Nadeen, she loves to tweet. And in fact, at the ACC, she was tweeting so much, educating everyone about what's going on, that I think she was rated as one of the ACC top influencers in the ACC Fed. So Nadeen, welcome. And I'll make sure I'll tweet this out today.
All right. Good morning, everyone. Thank you, Dr. Shah, for this very generous introduction. I plan to take you on a tour today to the world of structural heart disease as it stands today in 2019. I have no disclosures. I want to tell you exactly about our next stops over the last hour. We'll start with the aortic valve, then head to the mitral valve as a second stop, followed by the tricuspid valve. This is based on alphabetical order. If it were up to me, would only focus on the mitral valve, which is my favorite valve. I think everybody knows that. Due to the time constraints, we're going to cover the key papers that were published over the last few months. A lot has happened over the last few months, and I want to make sure everybody is updated. A little bit about myself. I'm an interventional imager in the making. This is a new specialty. It's a fascinating field that's rapidly evolving. We're basically trained in pre-procedural planning, procedural guidance, and post-procedural follow-up. And over the past few months, there have been several publications describing the role of interventional imagers in the structural heart disease world. Let's start with our first stop, the aortic valve. All right. Fasten your seatbelts. We're about to enter an area of severe turbulence. Can you hear the murmur? This is what aortic stenosis looked like in the past. You'd wait for the patients to have symptoms, and you'd always have this graph at the back of your mind, showing the decreased survival with each different symptoms. Luckily, nowadays, this is what aortic stenosis looks like. It all started in 2002 with the first human TAVR, and over the past several years, with multiple clinical trials, including patients at decreased surgical risk, we're now at a point where TAVR has been shown to be as effective as surgery in the low-risk population. And this is one of the major things that happened this year, where these two trials were presented at ACC, the Evolut low-risk trial and the Partner 3 trial. Dr. Kleiman and Dr. Reardon were part of the Evolut low-risk trial. I'm very happy to have trained under them. Let's start by talking about the Evolut low-risk trial. This was presented by Dr. Reardon at ACC. It's a multi-center, non-inferior, randomized controlled trial with the aim to compare outcomes with TAVR with a self-expanding biprosthesis versus surgical aortic valve replacement in patients at a low surgical risk. 1,468 patients with severe AS at a low surgical risk were randomized to either undergo TAVR with a self-expanding valve, and these included 734 patients. An additional 734 patients were randomized to undergo surgical aortic valve replacement. The primary endpoint for this trial was a composite of death or disabling stroke at 24 months. The baseline characteristics included a mean age of 74, so we're still talking about patients in their 70s, a mean STS score of 1.9%, which falls in the low risk, mean aortic valve area of 0.8 centimeters squared, and a mean aortic valve gradient of 47. In terms of the primary outcome, TAVR was non-inferior to SAVR. The primary outcome, which included death or disabling stroke at 24 months, showed that these two procedures were comparable, with an incidence of 5.3% in the TAVR group versus 6.7% in the SAVR group. In terms of the secondary outcome of composite of death, disabling stroke, major bleed, vascular complications, or acute kidney injury at 30 days, they were also comparable. At 30 days, patients who had TAVR with a self-expanding valve, as compared to surgery, had lower disabling strokes, less bleeding complications, less incidence of acute kidney injury, decreased atrial fibrillation, and note that about 35% of patients post-surgical aortic valve replacement developed atrial fibrillation. The TAVR arm, however, had a higher moderate to severe aortic valve regurgitation, which we'll talk about, and a higher incidence of pacemaker implantation, which was 17% in the TAVR arm with the self-expanding valve versus 6% in the surgical arm. Patients who underwent TAVR with a self-expanding valve had significantly lower mean aortic valve gradients and higher aortic valve areas as compared to the surgical arm. So they had better hemodynamic profiles after their procedures. Switching over to the Partner 3 trial, which was the other trial that was presented at ACC. This had the same objective of studying TAVR versus surgical aortic valve replacement in low-risk surgical patients, this time with a balloon expandable device. Patients were randomized to undergo either TAVR with a SAPIEN 3 valve versus surgical aortic valve replacement, and they were followed up at 30 days, 6 months, and annually through 10 years. The primary endpoint for this trial included a composite of all-cause mortality, all stroke, rehospitalizations at 1 year post-procedure. Baseline characteristics, the mean age was 73, very similar to the Evolut low-risk trial, where it was 74, so kind of similar generation. STS score, mean STS score was 1.9, exactly similar to the Evolut low-risk trial. And the mean aortic valve area was 0.8 with a mean gradient of 49. So the baseline characteristics of this trial are very similar to the Evolut low-risk trial. In terms of the primary outcome, which was a composite of death from any cause, stroke, or rehospitalizations, TAVR was superior to surgical aortic valve replacement. It's 15% for the surgical arm and 8.5% for the TAVR arm. In terms of the secondary outcomes, the TAVR arm had lower incidence of stroke at 30 days, less death or stroke at 30 days, and less incidence of new onset atrial fibrillation. And in this trial, the incidence of AFib was also in the 30%, similar to the Evolut low-risk trial. There was no significant difference in the major vascular complications. There was no difference in the incidence of pacemaker implantation. It was about 6.6% in the TAVR group versus 4.1% in the surgical arm. No difference in moderate to severe PVL, and there was no difference in valve hemodynamics. So our take-home point from these two trials, as Dr. Mike Rielden has said at ACC, we've now looked at a broad risk spectrum of patients, those at high, intermediate, and low surgical risk. And these years of trials have shown that TAVR is better than or as good as surgery in terms of disabling strokes and deaths from all causes. And this is Dr. Brunwald at ACC saying that this is a historic moment. All of us here should remember it as such. We will talk to our grandchildren about this, that we were here at the time this incredible advance in care of patients with aortic stenosis was presented. So we've come a long way since the pre-TAVR era until today. These are the main players in the low-risk trials. In the Evolut low-risk trials, the cord valve was used in 4% of patients, the Evolut R in 74% of patients, and the Evolut Pro, which is the newest generation, was only used in 22% of patients. So that's something to keep in mind when we interpret the results of these trials. In the PARTNER 3 trial, 100% of patients had the SAPIEN 3, which was the newest generation device at that time. And notice the presence of the skirts right here, and these serve to decrease the incidence of PVL. So if you want to be a trendy valve, then you should wear a cute skirt. This brings us to the new kid on the block, the Lotus valve. This is a mechanically expandable valve. It has central radio-opaque positioning markers, an adaptive seal here to, again, reduce PVL, and has a locking mechanism with a bovine pericardium from the inside. And this was studied by the PRIZE 3 trial, which Dr. Reardon also led. Included 900 patients with high to extreme risk surgical risk and severe AS. In this trial, the patients were randomized to either receive the Lotus valve or the core valve. So it was TAVR versus TAVR rather than TAVR versus surgical aortic valve replacement. Patients were randomized in a 2-to-1 fashion to receive the Lotus or the core valve. The mean age was 83, and the STS score was about 7%. The primary endpoint was the all-cause mortality, and all-cause mortality or disabling stroke at 2 years. This study showed that Lotus was as good as the core valve in terms of the primary outcome of all-cause mortality and disabling stroke. And it was also, there was no difference between the core valve and the Lotus valve in terms of all stroke incidence, but the Lotus valve had higher rates of disabling stroke. The Lotus arm had significantly higher pacemaker implantation rates, about 41%. After this trial, the valve and the liver system were redesigned to achieve lower pacemaker rates. Now the valve lands just distal to the annulus, and that serves to decrease the incidence of pacemaker implantation rates. The Lotus arm had higher valve thrombosis, 3% compared to none in the core valve arm. The Lotus arm had significantly lower valve migration, device embolization, or moderate to severe PVL. Hemodynamic-wise, the core valve did better with significantly lower mean aortic valve gradients and higher aortic valve areas. This is an example of a patient we had. 82-year-old high-risk surgical patients came to clinic with symptomatic severe aortic stenosis. We were part of the REPRISE trial, so he was randomized to undergo TAVR with the Lotus valve. And these are fluoroscopic images demonstrating the deployment process and the post-deployment process of the Lotus valve. And you can see those radio-opaque markers that were shown in the figure. And this is what the Lotus valve would look on echo. You can see it's well seated in the LVOT right here, above the LVOT, no PVL, and had acceptable gradients, and the patient felt better after the procedure. Last month, this Lotus valve was approved by the FDA for use in TAVR patients. And an important aspect to remember about this valve is that it's retrievable, repositionable, and removable until the final release. And this is the unique thing about this valve. So we've talked about the low-risk TAVR trials and the use of the Lotus valve for travel. Let's talk about the post-TAVR considerations, because TAVR includes follow-up, and we just don't stop when the valve is deployed and the patients feel better. There are things to consider after you see these patients in clinic post-TAVR procedures. It's important to identify complications. It's important to consider the valve durability and anticoagulation. This was posted yesterday by Mick Jagger. He just had his TAVR a few months ago. Patients will feel better, will have more energy, are able to do more things, but you always have to be able to recognize the complications. Let's talk about the big five. This was just recently published in JACC Cardiovascular Interventions, discussing the 5 peri-procedural complications of TAVR that impact outcomes. And these include stroke, PVL, bleeding, third-degree AV block, and AKIs. And they were called the Big Five in reference to the 5 most dangerous animals to encounter when you're on foot. Luckily, this year as well, we have new guidelines to help us detect one of these important complications, which is PVL. Dr. Zogby and Dr. Liller were part of the guideline writing committee. Actually, Dr. Zogby chaired this committee. And now we have a dedicated guideline to help us assess for post-TAVR and post-percutaneous interventions, complications by imaging. And if you look at the PVL section, there's a detailed description about the location of the PVL and how to describe it. And PVL can also be accurately quantified by measuring the vena contracta area and the percentage of circumference that the jet occupies. So this is a very helpful tool guide for all of us reading echoes and looking at post-TAVR imaging studies. Let's look at this case. This was a 74-year-old gentleman who underwent TAVR about 9 months ago prior to presenting. He came in with new symptoms of shortness of breath, lower extremity edema. An echo showed that the valve was thickened. You can see here there's some thickening with an elevated mean gradient of 25. When we looked at his immediate post-TAVR echo, his gradient was only 10. Given the thickening in the valve, we decided to do a TEE. Notice that there's no regurgitation that you can see on the transthoracic echocardiogram. And this was the TEE. And as you can see here, there's a mobile element, echogenic structure here that's moving freely, and it's consistent with a vegetation. And it's not causing any significant AI. It just was causing elevated gradients across the valve. Which brings us to this recently published paper from last month discussing the long-term risk of infective endocarditis in the TAVR population. That's not something we think about as often. This was an observational study, and it included about 2,600 patients with TAVR, 3,700 patients with SAVR, no history of infective endocarditis, and they were followed for 6 years. The study showed that the cumulative 5-year incidence risk of infective endocarditis was 5.8% in the TAVR group, 5.1% in the surgical AVR group, so they were not statistically different. The key point is, even though we don't think of it as much, infective endocarditis should be considered when we're seeing post-TAVR patients with severe, significant, aortic regurgitation or increased gradients. How about durability? This paper was also published as part of the NOTION trial, studying the durability of transcatheter versus surgical biprosthesis in patients at a low surgical risk. This was a prospective randomized clinical trial conducted in Europe. The mean age was 79, and the STS mean score was 2.9% for the TAVR group and 3.1% for the surgical AVR group. The surgical arm had different prostheses implanted, while the TAVR arm only had the core valve as their aortic valve. This is one of the most important definitions in this paper, which is moderate to severe structural valve deterioration. And what this means is a mean gradient more than 20, or increase in mean gradient of more than 10 since implantation, or more than mild intraprosthetic aortic regurgitation, either new or worsening 3 months post-procedure. And this study demonstrated that the TAVR group had a lower incidence of moderate to severe structural deterioration at 4.8% compared to 24% for the surgical arm. There was no significant difference in the non-structural valve deterioration, which includes significant PVL or patient prosthesis mismatch. And there was no difference in biprosthetic valve failure, which is defined as valve-related death, reintervention, or severe hemodynamic structural valve deterioration. And the incidence was about 7% for both arms for the biprosthetic valve failure. So they're not different in that regards. This study also showed that hemodynamically, the TAVR valves did better with lower gradients and higher areas. Moving on to anticoagulation. In October 2018, the Galileo trial was terminated. And this is the study design of the trial. So patients who underwent TAVR were either randomized to rivaroxaban and aspirin for 3 months versus Plavix and aspirin for 3 months, after which the aspirin was dropped in the rivaroxaban arm, and the Plavix was dropped in the aspirin Plavix arm. In October, Bayer issued this statement saying that the trial was terminated early based on the prelim results showing an increase in all-cause mortality, thromboembolic and bleeding events in the rivaroxaban-treated patients, and that the analysis was ongoing. So the take-home points for the post-TAVR studies, the incidence of infective endocarditis at 5 years was not statistically different between the surgical arms and the TAVR arms. In the NOTIOL trial through 6 years, structural valve deterioration was significantly greater for SAVR than TAVR, whereas biprosthetic valve failure was low and similar in both groups. The question of optimal antithrombotic regimen post-TAVR remains unanswered, and multiple clinical trials are underway trying to answer this very important question. The question is now, TAVR sounds very attractive, and it's easy to explain to the patient that they're only going to end up with a small puncture site in their groins, speedy recovery, but is TAVR for everyone? And this is Mick Jagger again, recently had his TAVR, and it reminds me of one of the lyrics for the Rolling Stones songs. You can't always get what you want, but you find you get what you need. And this brings us to the importance of informed shared decision for patients with severe aortic stenosis. Things to consider are age, durability of the valve, other comorbid conditions like the need for aortic surgery, coronary artery disease, and things like that. So at the end, it should be a patient-centric approach, just focusing on what benefits the patient the most, and age is definitely a huge part of that. Unfortunately, in the aortic stenosis world, age is not only a number. Okay, our second stop, the mitral valve. Please wear your 3D glasses for optimal viewing. This is definitely a 3D world. Start with this case. This is an 84-year-old patient who was referred to us for MitraClip evaluation, had a TEE performed at an outside hospital showing a P3 flail with severe MR. He was a high surgical risk patient, so he was referred to us for MitraClip consideration. The patient did not have any 3D imaging of his mitral valve when he came to see us in clinic. So we did our own TEE, and this is what we got. You can definitely see the P3 flail right here. This is the aortic valve anteriorly, the appendage laterally, the septum, and this is the posterior wall. So you see the P3 flail right here, but you also see an anterior cleft, and that has implications in terms of procedural planning. So 3D is very important when evaluating mitral valve pathology. And this was demonstrated by a recent paper published in JACE, where about 1,000 patients with moderate or severe unexplained MR were referred for TEE. Out of these patients, about 600 had 3D studies, and out of these, about 3% of patients were identified as having mitral valve clefts, most commonly in the anterior leaflet, specifically in A1. So it's very important to, when performing a TEE study to evaluate mitral valve pathology, 3D is key in identifying the cause of regurgitation. This brings us to our second device, the MitraClip. And this is what it looked back then before 2018, 2019. We were using MitraClip for treatment of primary mitral regurgitation. You see here a P2 prolapse. But now we have two trials, the MITRA-FR and COAPT, discussing the role of MitraClip in functional MR. And these were presented late 2018. Let's talk about MITRA-FR trial. This trial was conducted in France. The patients had severe secondary MR with an effective regurgitant orifice more than 20 millimeters squared or regurgitant volume of 30 cc's. This is severe per the European guidelines. Patients had an EF between 15 and 40%, and all of them were symptomatic despite guideline-directed medical therapy. Patients were randomized to either receive percutaneous mitral valve repair with a MitraClip, and these included 152 patients, versus medical therapy, and this included 152 patients. The primary outcome included a composite of death from any cause, or unplanned hospitalizations for heart failure at 12 months. Baseline characteristics, the mean age was 70 years. More than 50% of patients had ischemic cardiomyopathy. More than 50% of patients had class 3 symptoms. The mean left ventricular ejection fraction was 33%. The mean left ventricular end diastolic volume was 135 cc's per meter squared, and an effective regurgitant orifice of 0.31 centimeters squared. This trial did not show any difference in outcomes between patients who received the MitraClip for treatment of functional MR versus medical therapy. In contrast, this is the co-op trial, which was conducted in the United States and Canada, and also included patients with moderate to severe or severe MR. The EF ranged between 20 to 50%, with an LV end systolic dimension less than 7 centimeters. All of these patients were symptomatic on guideline-directed medical therapy and had at least one heart failure hospitalizations or elevations in their BNP. They were randomized to either receive the MitraClip therapy plus the guideline-directed medical therapy, and these included 305 patients, versus medical therapy alone in 305 patients. The primary outcome included all hospitalizations for heart failure within 24 months of follow-up. The baseline characteristics, again, patients in their 70s, more than 50% with ischemic cardiomyopathy, more than 50% with class 3 symptoms. Mean EF was 31% in contrast to the 33%, so very similar so far in terms of the baseline characteristics to the MitraFR study. But these patients had smaller ventricles with a mean left ventricular diastolic volume of 101 cc's per meter squared and effective regurgitant orifice of 0.4 centimeters squared. So smaller ventricles and more severe MR, basically. And this was the historic moment at TCT.
Shows the primary effectiveness endpoint of all hospitalizations for heart failure within 24 months. In the control group, there were a total of 283 heart failure hospitalizations in 151 patients. This was significantly reduced in the MitraClip group to 160 heart failure hospitalizations.
And it received standing ovation, as you can see. The number needed to treat was 3. The MitraClip was also associated with a mortality reduction in the device group as compared to the control group who received the optimal medical therapy. And when you compare it to the guideline-directed medical therapy medications, ICDs, and CRTs, the MitraClip device was associated with a 42% decrease in mortality. And this was major news for all the structural heart disease cardiologists and the heart failure specialists. So how do you compare the MitraFR versus the COAPT? And I was very happy that Dr. Greg Stone was here not too long ago explaining this in details, but just to touch on the main points. MR was more severe in the COAPT group versus the MitraFR group. The LV size was also larger in the MitraFR. So with the COAPT, we had patients who had smaller ventricles and more severe mitral regurgitation. The guideline-directed medical therapy at baseline and follow-up was more tightly controlled in the COAPT arm. And lastly, there was more significant residual MR in the MitraFR group and higher degree of procedural complications in the MitraFR group as compared to the COAPT trial. All these can explain the differences in the outcomes of these two trials. Based on the results of the COAPT trial in March 14th of 2019, the FDA approved the MitraClip device for valve repair in patients with functional MR. That was major news. To help us with the post-MitraClip valve assessment, Dr. Little, Eleonora Avenatti, and Carlos and Dr. Barker here published this paper recently demonstrating the use of vena contracta area post-MitraClip implantation to determine patients with moderate or more than moderate mitral regurgitation. This is challenging post-MitraClip because sometimes you end up with multiple jets. So what they've done is that they've calculated a sum of all the vena contracta areas for the different jets. The magic number was 0.27, and it was shown to have a good diagnostic accuracy to determine patients with moderate or more than moderate mitral regurgitation, and it had a negative predictive value of about 93%. So our take-home point for the MitraClip world, in my mind, is that before you consider anyone for the MitraClip intervention, it's important to make sure they're on maximally tolerated guideline-directed medical therapy. And it's important to carefully select your patients, because the real difference between the two trials was in the patient selection process. We have all our patients see our awesome heart failure specialist, and a lot of these mitral regurgitation patients actually have a decrease in the severity of their mitral regurgitation before they get to the stage of needing a clip. So guideline-directed medical therapy and optimal heart failure care actually works for MR. If it doesn't, then we have a solution right now. We can perform the MitraClip procedure for favorable outcomes. But just skipping to a MitraClip procedure is not the answer, and the trials have demonstrated that. We should keep that in mind. All right, shifting gears. We're going to talk about transcatheter mitral valve replacement, including a valve and native valve and valve and MAC. Recently, the largest transcatheter mitral valve replacement series experience has been published. And this was the initial feasibility study of a new transcatheter mitral prosthesis, the Tendyne prosthesis by Abbott. And this figure shows the device, an inner stent, an outer stent, and this is an apical tether. Because remember, all these transcatheter mitral devices will have to withstand the pressure generated by the LV, so you need to have a good anchoring mechanism. So this specific device had an apical tether, and we'll talk about it in a little bit. The patient population included patients with symptomatic grade 3 or 4 mitral regurgitation who were poor surgical candidates. Exclusion criteria included left ventricular end diastolic dimension more than 7 centimeters, EF less than 30%, severe mitral annular calcification or leaflet calcification, severe pulmonary hypertension, RV dysfunction, or severe TR. The mean age of this patient population was 75 years old, and 39% of these patients had hospitalizations for heart failure in the last 6 months. The mean EF was 46, an STS score of 7.8%, and the majority had secondary MR at 89%. And this is a video demonstrating the deployment process. This is a transapical mitral prosthesis. So the apex is punctured, the delivery system and the sheath are introduced into the left atrium, and then the valve is deployed. And then it's anchored to the apex by an apical tether. Imaging is very important to avoid injuring the subvalvular apparatus because you're going through the apex into the mitral annulus. This study showed that the Tendyne prosthesis was effective and safe. There were no intraprocedural deaths. Technical success was achieved in 96% of patients. The 30-day mortality was 6%, 1-year mortality of 26%. And among patients who survived to the first year, about 90% had mild or no symptoms. And as you can see, the device was very effective in reducing the degree of mitral regurgitation. The green bar here represents none or trivial up to 12 months post-procedure. So there were no intraprocedural deaths, no device embolization, no acute conversion to surgery or need for cardiopulmonary bypass. I'm going to show you a case of one of our patients who underwent a valve and native valve. This was an 80-year-old patient with depressed EF and severe functional mitral regurgitation. In this case, we used the Intrepid valve, a different valve which has an atrial skirt and a ventricular skirt that's more stiff and slightly larger than the annulus to ensure its anchoring to the annulus. When you're doing these procedures and you're aiming for transapical access, you want to identify the apex. And this is kind of a group effort. So you have the surgeons poking from the outside, as you see right here. You see the LV getting pushed at the apex. This helps identify the apical site. And also, you can also see the finger here on fluoro. This must have been Dr. Reardon. At the same time, we also use CT with CT markers on the fluoroscopy screen to provide further guidance into the optimal transapical puncture site. This is the valve deployment, and again, you have to, imaging is key here because you want to avoid all the subvalvular apparatus as you're advancing the sheath and the device. This is the valve being deployed. This is the deployment process on fluoro. And again, CT is key in pre-procedural planning for TMVR. This is post-deployment of the Intrepid valve. You see that the valve is well-seated and stable, doesn't move much, and by angiography, there was no residual MR. The patient also had a mean gradient of only 2 millimeter after the valve deployment, had normal prosthetic function. All right. Moving on to valve in MAC, because MAC is a scary word. It scares everyone. Nobody wants to touch a patient with severe MAC, and it's a very challenging pathology to have for surgeons and interventional cardiologists. So this was a lady we saw in clinic who came in with class 3 to 4 symptoms, extremely fluid overloaded, with an echo showing significantly calcified mitral annulus, thickened leaflets, and an elevated gradients across her mitral valve. She was at a high surgical risk, so we had a heart team discussion as to the best options for treatment of her mitral valve disease. She also had aortic stenosis, but the question more was of the mitral valve stenosis part. As part of the pre-procedural planning, she underwent a CT study to help with the available options, and this is a 3D CT reconstruction of her mitral annular calcification. It's circumferential, and it's also extended to the inferobasal walls. And you can see a 3D digital reconstruction from her CT study, and a 3D printed model here to show the extent of the MAC. And this is very helpful when you're planning an intervention in terms of device sizing and prediction of complications and things like that. So what are the challenges associated with MAC? First, there's a risk of periprosthetic valve regurgitation because of the circumferential nature of the MAC. If you try to debride it extensively, this can risk injury to the left circumference artery, annuloventricular disruption, and most importantly, MAC is associated with LVOT obstruction when you're considering mitral valve replacements. And TMVR is really the Achilles heel of transcatheter mitral valve replacement, because every time you go percutaneously and try to deploy a valve, there's a risk of the LVOT getting obstructed. And imaging, again, is key in predicting this feared complication. There are simulation softwares that allow you to virtually implant a device and calculate the area of the LVOT post-implantation to determine the patient's risk for having LVOT obstruction. Sometimes with surgery, when you deploy the valve, you're able to resect the anterior leaflet, and that decreases the risk of LVOT obstruction. More recently, the Lampoon procedure has been described for percutaneous interventions, where this anterior leaflet is lacerated to decrease the risk of LVOT obstruction. So after our heart team discussion, we decided to pursue transatrial valve in MAC. This is not our patient, but one of the recent studies that were published, just to show you the images. The anterior leaflet is first resected, and sutures, the calcium is removed from trigone to trigone, and sutures are placed in the anterior annulus. For our patients, Dr. Rule didn't even have to touch the posterior annulus. He was able to just place sutures through the anterior annulus. The SAPIEN 3 is prepped, sized with a balloon, and then deployed and secured with sutures around the anterior annulus in our case. So this is a new technique that's been recently also described. This is our patient with her heart-shaped mitral annular calcification pre, and with a nice SAPIEN S3 in MAC post-implantation. She did very well and felt better. And this is a TEE post-deployment. No residual MR with good gradients. She also had an aortic valve replacement at the same setting. Which brings us to this paper describing this technique of open atrial valve in MAC with the balloon expandable SAPIEN 3 device. And this included 8 high-risk surgical patients. The technical success was 100%. In-hospital and 30-day mortality was 0%, and the immediate post-implant PVL was less or equal to mild. So effective, safe, short-term, recently described. But again, the patients with MAC are a very challenging population, and hopefully as time goes by, we'll be able to refine all the different procedures and options we have for them. So our tour take-home point for the transcatheter mitral valve replacement arm is that the Tendyne prosthesis was shown to be highly effective in relieving MR, improving symptoms with an acceptable safety profile. And there are many, many, many other devices out there that can be used for transcatheter mitral valve replacement. But based on my inclusion criteria for the talk, I'm just mentioning the papers that were just recently published. And LVOT obstruction is the Achilles heel of TMVR and should always be considered in the pre-procedural planning and post-procedural imaging follow-up of patients. Open atrial transcatheter mitral valve replacement has been reported in patients with severe MAC and can be considered as an option in their management. Okay, our third stop. We're now entering an uncharted territory with torrential jets. Please wear your flotation devices. This is the bottom line. TR is terrible, and Dr. Little can attest to that. It is terrible that it's associated with bad outcomes. It's still, the percutaneous options for tricuspid regurgitation is not as well established as the aortic stenosis and the mitral regurgitation patients, but we're getting there. TR is terrible to the point where you sometimes look at an echo and you feel like you want to call it severe, but it looks way more than severe. So Dr. Zogby and Dr. Han just published this new proposed grading system, which includes severe, massive, and then torrential MR. This is one of our valve clinic patients who had a history of open heart surgery and had a tricuspid ring for treatment of tricuspid regurgitation, came to see us with severe right-sided heart failure symptoms, abdominal distension, fatigue, edema, couldn't walk far, and this was her echo. How severe do you think the TR is here? You have the jet filling the right atrium, you have early equalization of pressures, V-wave cutoff sign by Doppler, IVC is dilated, and you have systolic flow reversal in the hepatic veins. So she had significant TR, and she was very symptomatic. At the same time, she was a very high-risk surgical patient. So what we've decided to do is 3D print her tricuspid valve with a tricuspid ring, because every time there's a ring, that poses challenges for procedures and imaging guidance. And through 3D printing, we were able to identify the coaptation gap and the optimal site for our treatment option, which was a MitraClip device. Took the patient to the cath lab. This was her baseline study showing the tricuspid ring with severe tricuspid regurgitation. For MitraClip positioning, we use the transgastric views, and this varies depending on the patient. And unlike the mitral valve where you go to 60, you get the 3D and you're there, the tricuspid valve is way more challenging, and you have to try different views and different angles and to get your optimal implanting view. And these are the transgastric views demonstrating the clip positioning process. You can also see it on fluoro. This is the MitraClip deployment. This is short axis transgastric. This is the long axis. Significant improvement in TR after the clip deployment. And the 3D printing aspect really helped us target these leaflets and mild residual TR at the end. And again, 3D imaging, which shows you the MitraClip device. This brings us to the Trivalve Registry, which is the largest worldwide series of patients treated with transcatheter tricuspid interventions for TR. And this was published again this year in 2019 and included 312 high-risk patients with severe TR. The characteristics of the patients included a mean age of 76. The majority of patients were females. That's very infrequent to see. I'm glad to see that more females are being enrolled in trials. 35% of patients had prior left heart valve interventions. The Euroscore was 9, and 95% of patients had a functional class of 3 or 4. Echocardiographically, the TR was functional in 93% of patients with a mean annular diameter of 46.9 millimeters. The jet was central in the majority of cases. The mean vena contracta was 1.1. The PA systolic pressure was elevated at 41. And these were the devices that were used in this large registry. We have the annular devices that serve kind of as annuloplasty devices, the cardioband, tricinch, trialign. We have the caval valve that goes into the cava. This was used in 9%. Coaptation device, which is the forma, and it sits right here where the leaflets coapt and they decrease the malcoaptation gap. The navigate valve was used in a minority of patients, and so was the Pascal, which is the new clip by Edwards. The MitraClip device was used in the majority of cases, and it works the same way as it does for the mitral position, approximating the leaflets together. This was used in 66% of patients. The procedural success was 73%, and this was defined as residual TR of less or equal to 2+. There was a significant reduction in TR, as you can see, at 30 days. And patients with procedural success actually had better outcomes in terms of survival. So they lived more than patients with procedural failure. The greater coaptation depth was the factor that was associated with reduced procedural success, which brings us back to the point of the importance of imaging and pre-procedural planning in all of these structural cases. So transcatheter tricuspid valve interventions are feasible with different technologies and are associated with low mortality and significant clinical improvement. Our last stop, home tour. So as you can tell, the structural heart disease world has been expanding. I mean, over the last 6 months, I was able to find multiple practice-changing studies that were published. And as it continues to expand, we're expanding our structural heart disease program at Houston Methodist under the leadership of Dr. Stephen Little. Everybody knows Dr. Stephen Little, and I can't think of a better person to be leading our structural program here at Houston Methodist. A little bit about our program. We have a valve clinic with more than 1,300 visits a year. Our annual MitraClip volume continues to climb. We're about 50, and by end of 2018, and the same goes for our annual TAVR volume. So the field is growing, and we're growing with it. Just a short list of the clinical trials that we have in our structural heart department, where we enroll patients in trial, follow them up, and we have multiple upcoming new clinical trials. So we're always offering the latest advances to our patients. All right, I hope you've enjoyed our tour in this fascinating world of structural heart disease. As we prepare for landing, I want to thank our captain, Dr. Zogby, who's watching from the Dominican Republic, for his leadership and vision. My mentor, Dr. Little, for training me this past year in structural heart imaging. My mentors, Dr. Barker and Dr. Kleiman. And I'm very fortunate to be staying on as faculty, and I look forward to taking off again on another adventure in July. Thank you.
All right, well, that was phenomenal. I mean, you did really an outstanding job, and it's hard to believe this is only May, and these are all the advances that we've seen in this year alone.
By like October.
So also, I've got a comment from somebody that's watching live. Dr. Zogby's at the Dominican Republic, and he wanted me to tell you, superb presentation, not only a tour of valvular heart disease, but a tour de force. And he's expecting much more from you, or continued from you, superb presentations as you become faculty. So we got a few minutes for questions. Any questions from the audience?
So fantastic work, Nadeen. I know that you and Dr. Little stand in the forefront of radiation in the cath lab. What's being done at this point to minimize radiation to operators who are imaging? Mm-hmm. We know the interventionalists are shielded pretty well with the devices. The tables are usually set up for them. So what's being done to minimize radiation and ensure safety for you guys?
That's a great question. Thank you, Shadon. And this is addressed in some of the publications that I mentioned previously about the role of interventional imaging. So again, the most important thing is distance. So where you're not actively acquiring pictures, it's always important to kind of step back. We have radiation pads that go on top of the patients and reduce the amount of radiation that's getting to the imagers. We have radiation skirts. Dr. Little has an extra safety layer. I do this and I do that when he's try to protect him as much as I can so I can learn the best. But it is an issue and it needs to be addressed. And a recent study showed that the imagers are actually getting more radiation than the primary operators. So that's an area where we need further work and advocacy.
I'll just comment, if I could, Nadeen. So again, thank you for this great presentation. It was very bold to take on a tour of that magnitude, and you did a great job. One of the issues for the radiation exposure is really just maximizing pre-procedural imaging. So the more CT you have, the more planning you have ahead of time, the more radiation that is used before the procedure as opposed to in the procedure really makes a big difference. So I think probably that's the main thing, and picking larger fellows to hide behind. That's really the goal.
Nadeen, you mentioned the antithrombotic regimen after TAVR valve sort of being an area of uncertainty, although it sounds like at least Xarelto is a no-no.
Don't use
What do you do to people who are on a DOAC pre-TAVR who are going to be getting a TAVR? Are you switching them to warfarin? Are you leaving them on it and switching it after? And then what are you doing in your practice for dual antiplatelet therapy after a TAVR?
So this is a very important question and reminds me of one of the Valve Summit talks of last year. I don't think we switch anyone from their DOACs. We just continue what they're on. We make sure they're on antiplatelets after the TAVR. And again, we still don't have any strong data. That's why multiple trials are currently underway and hopefully we'll have some more answers for us. We don't typically change to Coumadin if they're already on DOACs before the TAVR. And again, it's very attending specific in different institutions.
Okay, well, great. That was, again, phenomenal.
Thank you.
And let's give a big round of applause to Nadeen.
Thank you, Dr. Shah.